Assalamu alaikum. My name is Javed Raza, a member of the academic wing at Ventilators for Pakistan. I would like to welcome everyone to the seventh session of our COVEB series, where we will be discussing general surgery with respect to COVID-19. Our experts will be shedding light and giving their insight on how COVID-19 has impacted surgical practice and the protocols that must be taken. I would like to reiterate that this session is part of the COVEB educational series that are taken up by Ventilators for Pakistan. From its humble beginnings, Ventilators for Pakistan is an effort to support the healthcare system of Pakistan. VFP has become a name of its own, thanks to the visionary guidance of its own founders, Dr. Sabah Akhtar and Dr. Rabiel Tariq, as well as the unrelenting efforts of all its members. Every week, we would like to put the spotlight on one of our teams and the work that they have done. This week, we would like to highlight the work done by the Home Management Program team. The directors of the home management team are Dr. Amna Ijaz, Dr. Mohammad Daniel Hashmi. Its members are Mr. Ali Gohar Bhutto, Ms. Temina Mariam, Dr. Maheen Mujtaba, Mr. Mohammad Muntazir Khan, Dr. Yashfin Malik, and Dr. Ali Mohsen. The home management team has been diligently working on several projects which will allow for the management of mild to moderate COVID-19 symptoms at home. The team has ensured that all information is presented to the public in an easy to read and concise manner. Additionally, they have provided information in both English as well as Urdu. The home management team has also been able to raise enough funds to provide much needed pulse oximeters to several different organizations and some basic healthcare units and rural healthcare centers. The home management team will continue to provide information regarding COVID-19 care to help fight COVID-19 on the mass of Pakistan. The individuals involved are making a key difference in the fight to COVID-19. Over the next few weeks, we would continue to share the efforts that VFP have been making to combat this deadly disease. Now, without further ado, I would like to introduce the co-director of the academic wing of VFP and my co-host for the evening, Dr. Mehwish Erkan.
Assalamu alaikum. Thank you, Dr. Zaid. It is an honor to co-host this COVEB educational series. I'm the co-director of the academic wing for VFP and also the co-founder for Yarden Foundation. My sister and I founded this foundation about a year ago, and the intention was basically to help the marginalized sections of our nation. We currently have 3 running programs, but I would like to mention FRP, which is a food and ration program that we started during the pandemic and have so far helped 800 plus families during the lockdown with enormous help from the transport company Move It, being run by Mr. Hassan Mirza and Mr. Uzair Khan, without whom it would not have been possible. The FRP team is run by Ms. Lareb and Mr. Ahmed Bukhari and includes a team of hardworking members, Ms. Hafsa Javed, Mr. Mohammed Musa, Ms. Saida Ghazia Nadeem, Ms. Aisha Hussain, Mr. Rafit Atiq, and Mr. Ibrahim Oskan. In May 2020, it was published in the Washington Post that the consequences of the coronavirus pandemic may prove more devastating than the disease itself for the world's poorest countries. In fact, even before this pandemic, it was established by WHO that in every 10 seconds, a child dies of malnourishment. Due to the overwhelming support we received, we started a long-term program to provide monthly ration to families with no means of support, such as widows, divorcees, orphans, handicapped, and disabled persons. In this program, sponsors can choose to provide funds to cater to a family for a specific time period, a month, 3 months, 6 months, even an entire year. Our members purchase, pack, and deliver the ration packs personally. We have located many deserving families who need our help. An example I would like to share is of a man who has been chained to a wheelchair for most of his life. Despite the constraints of his amputated limbs, he believes his real disability is the hunger and poverty that growls in his stomach and prevents him from running his shop and providing for his family. Many people like him want to live a dignified life just like the rest of us. They want their worth to be measured by the hard work and honesty of their work rather than the degree of their poverty. Now I would like to mention some personalities without whom this web series would not have been possible. The patron-in-chief for these series is Professor Emeritus Lieutenant General Mahmood Ahmed Akhtar, Hilal Imtiaz Military. And our patron is Professor Dr. Samia Naeemullah, recipient of the President of PAC Gold Medal by Pakistan Pediatric Association. Thank you so much, sir and ma'am, for your support. I would also like to take this opportunity to particularly thank Rawalpindi Medical University, which has accredited these education series for all of us to enjoy. Thank you so much to the Vice Chancellor and the medical education team of RMU. Participants, please do remember to subscribe to our YouTube channel and follow our Facebook page. During the live session, don't forget to comment with your name and along with your designation. And in the end, make sure to fill out the feedback form to mark your attendance. Over to you, Dr. Zaid.
Now, I'd like to introduce the first speaker of the evening, Professor Dr. Mohammad Mussadiq Khan. Professor Dr. Mohammad Mussadiq Khan is a diplomate American Board of Surgery, FACS, FCPS Pakistan, and FICS. He is a consultant general and vascular surgeon currently working at Shifa International Hospital, Pakistan. Dr. Mussadiq did his surgical residency in general surgery from Allegheny General Hospital, Pittsburgh. He also did a fellowship in traumatology. Dr. Mussadiq held senior positions at renowned institutions. He was a former head of department at surgery at Rawalpindi Medical College. He has also held many positions as chief executive of Allied Hospitals and Principal Rawalpindi Medical College. Professor Dr. Mussadiq is also a former member of the PMDC and is currently the member of the Association of Pakistani Physicians of North America. His past experiences in conjunction with his progressive and diverse approach have ushered in a rapid growth which has led to a devoted patient base. Professor Dr. Mussadiq Khan continues to make medical procedures and technology incumbent while serving people from all walks of life. Now I'd like to introduce Dr. Mussadiq.
Assalamu alaikum, sir.
Assalamu
Wa alaikum assalam. It's indeed a pleasure to be here with you people and to share something about surgical practices during COVID-19. But before I start my presentation, I would really thank your organization, Ventilators for Pakistan, for the work they are doing to improve the healthcare facilities in Pakistan. Anyway, the topic that I'm going to discuss is emergency surgery do's and don'ts during the COVID-19 pandemic. As all of you know that this novel coronavirus emerged in Wuhan in China in December 2019. WHO declared it a public health emergency of international concern on the 30th January 2020 and a pandemic on 11th March 2020. This pandemic infection has involved more than 200 countries. It's a systemic disease and it is very contagious. The current status of this disease in Pakistan as of August 14, 2020, that we have over 288,000 confirmed cases. We have reported deaths in the range of 6,162, and we have got more than 265,000 reported patients who have recovered. But I'm sure there's a lot, might be a lot different on ground. Now, in third week, when this, after this came, we came to know about it and sort of a panic was created. Then in third week of March 2020, a decision was made to take special measures in surgical practice in our hospital in view of this COVID-19 pandemic. And because of that, what we did was that all routine elective surgeries were stopped and all routine OPD services were stopped. Immediate emergency surgeries were only performed in specific specific isolated operating rooms with full protective measures. As without the results of COVID-19 PCR, every patient was considered to be potentially a positive case. Urgent surgeries were performed after getting the results of COVID-19 PCR, which in our hospitals, the report we were getting within 12 hours. If the report was negative and there was no added suspicion, then operations were performed in general operating rooms with routine protective measures. But if the report came back positive or we had a high suspicion of COVID-19, despite a negative report, then the operation were performed in a specific isolation operating room with full protective measures. As I told you before, routine OPD activities were stopped. All hospital employees were evaluated, and high-risk employees were requested to stay at home. That is, people who were above the age of 70 or had significant comorbidities. They were requested to stay home, and they stayed home for about 3 months. Now they have started coming back to work. Only one attendant was allowed to be with the patient in hospital for those patients who were COVID-19 negative cases. As far as COVID-19 positive cases are concerned, we kept them in complete isolation. All laparoscopic procedures were stopped. And in case, say like a cholecystectomy, there was a patient who required an urgent cholecystectomy because of empyema, gallbladder or so, then laparoscopic procedures were not done. And these operations were carried out by means of open surgery, because the increase in intra-abdominal pressure results in dissipation of fluids and air from inside the patient's body, and that spreads in the atmosphere. And if those patients were positive, then that would result in spread of the disease. So laparoscopic procedures were stopped for a period. Now, what is emergency surgery? It is defined as a surgery that is required to deal with immediate threat to life, organ, or limb. And we know that delay in surgery in these patients would result in significant morbidity and mortality. I'll give you an example that during Eid al-Fitr, we received a 23-year-old man who had received a gunshot wound to the thigh. He fell after the gunshot wound, resulting in a head injury also. He was brought to the emergency room, and there was a suspicion of him being COVID positive, though he did not have any clinical features prior to that, prior to this gunshot wound, which would make us think of COVID-19. But he underwent an emergency HRCT, which showed changes in the lung, which could be consistent with COVID-19. So he was operated, and he underwent a 6 hours long orthopedic vascular procedure in our designated area, isolated operating room, where full protective measures were taken. Subsequently, he was shifted to the COVID critical care area. His PCR report came back positive, and he was managed there. And by the grace of Allah, he recovered from all his conditions and was discharged. Now, what is the impact of surgery? Or at least what was the impact on surgical department? In the hospital, initially there was an acute shortage of personal protective equipment, gowns, masks, but with the passage of time, steps were taken, and should be ensured that there is abundant supply of these things. We had limited number of ORs, rather only one OR that could cater to these emergencies in suspected or proven cases. We have a number of OR which could cater to the operation of patients who were declared negative, but only one operating room was fixed for the patients who had proven or suspected cases. And timing, as all of you know, is very important in care of surgical emergencies. Now, what were the surgical preparations that we took? All patients were seen by the staff wearing proper physical protective equipment, including N95 masks, goggles, shields, impermeable gowns. COVID-19 PCR test was performed on all patients, and the results were made available within 12 hours. We had facilities of doing a high-resolution CT scan in wherever it was indicated. During the operation, the intraoperative measures, all the operations were performed in designated isolation operating rooms where we had negative pressure. That means the air was being sucked out of the room. And all these procedures were done following a laid down protocol, including proper disposal of the material after the operation. Post-operatively, we continued all our precautions, and patient was kept in isolation till we received a negative PCR. If the PCR report was negative, but we still had a high index of suspicion of COVID disease, then we would carry out HRCT in them. Now, the specific conditions that required emergency surgery where we could not, or where you cannot even wait for the results of PCR, are like life-threatening trauma, cardiothoracic issues, cardiac tamponade, airway obstruction, pneumothorax. You have to remember that whenever you have airway obstruction and you have to intubate the patient, then your anesthetist is, or a person who is carrying out the intubation is at a very high risk of getting COVID-19 infection if the patient is infected, because the virus resides in oropharynx and nasopharynx. Similarly, the emergencies which cannot wait are like complete bowel obstruction, not being managed by conservative therapy, gastrointestinal perforations, volvulus, mesenteric ischemia, different types of peritonitis. Similarly, genitourinary diseases like testicular torsion, strangulated hernias, priapism. Similarly, there are gynecological conditions like bleeding ectopic pregnancy, emergency deliveries, neurosurgical emergencies like intracranial bleeding, vascular emergencies, ruptured leaking aneurysms, limb ischemia. We saw quite a few, rather. I remember there are at least 3 cases of limb ischemia that were operated without, even before we had the results of PCR, and we had to take all the measures that I had described before, and I'll be describing subsequently also. We have to remember there are certain conditions which normally we operate, but these are the conditions that can be managed conservatively initially or completely. Appendicitis is one of them, cholecystitis is one of them, necrotizing pancreatitis, similarly perianal abscess, complicated hemorrhoids. I mean, there's a whole list of conditions that normally we operate on them. But in these circumstances of COVID-19, we would either manage them conservatively initially, or at times we would manage them completely non-operatively, utilizing supportive services as much as possible, using a team approach with the help of interventional radiology and gastroenterology. Now, the specific operating room that I've been talking about that was being used for COVID-19 positive or suspected patients, as I told you before, it has a negative pressure. We make sure that there's a minimum staff that is present in the room, especially during intubation. Full PPIs are used by everyone. Minimum equipment is present in the room, but all the necessary equipment is present in the operating room. There is proper disposal mechanism of the material after the operation. Once the procedure is done, all workers, they take a shower before and dispose of their equipment before they leave the operating room suite. Full sleeves gowns with caps are worn by the workers. Then once they have used this equipment, then the sterilized disposable gowns is worn on top of it. N95 mask is used with a surgical mask covering on top of it. Protective goggles are used, or a face shield is used. Waterproof shoe covers are used. Long boots to be placed with disposable shoe covers on top of it are used. Similarly, sterile disposable waterproof gowns were used. Disposable gloves were used. The staff, besides the surgeon, anesthesia, scrub, circulating, housekeeping, were involved in it. Pre-assigned staff as procedures. We took all precautions to keep the number at a minimum as per the actual need of the procedure. Only those healthcare workers were allowed who were trained in these environments and were specifically designated to carry out these procedures. The important reminders are that disposable surgical drapes should be used for all the procedures. Maintain a supply of proper personal protective equipment. Dedicated equipment, anesthesia, and medication in cart trolleys were used. Detailed education of OR staff on infection prevention strategies, including visual reminders, were used. Defined roles and responsibilities of each team member. There was a runner outside the operating room who would retrieve medication, instruments, and other supplies. Utilization of mobile and line to request needed item from the runner. Transfer of patient through the designated route and door. Waste management and PPI handling and disposable as per the hospital guidelines. In preoperative care, all staff will go direct to the respective floor to receive the proper handing over of the patient using the proper standard protocol, wearing the proper PPEs. Safe surgical protocol were to be observed. After handing over the patient was to be moved directly to the pre-selected operating room that I have described. All patients were to wear a mask that was mandatory. A dedicated surgical staff will assist in the procedure. Strict universal precautions will be observed during the procedure. Safe surgery protocol will be observed during the procedure, except for authorized staff. Entrance would be restricted during the procedure. Disposable items will be used in the entire procedure. Standard intraoperative care will be observed in the entire procedures. Door will be kept closed during the procedure and will be open only when patient has to be transferred to the next level of care. Routine post-operative care was given inside the operating room and not in the recovery room. Patients will be sent directly to the surgical ICU or in any room assigned by the dedicated post-op staff with proper protective equipment. All specimen would be sent directly to the lab in proper container with double bag precautions. OR will be washed with neutral water and detergent and serviced decontamination with the use of approved chemicals. A mixture of 1 part of bleach and 9 parts of water is recommended for floor and surface cleaning. Antiseptic spray is used for cleaning the air. A minimum of 2-hour gap shall be adopted in between the cases to allow proper decontamination of the area. Dedicated housekeeping staff would wear the required PPE, head, face, and hand covers and gown. All items that were used during during the procedure will be disposed in a biohazard container. Solidifier will be used in all fluid waste and will be dispensed in yellow bags. All bags will be disposed immediately after from the operating room to be sent to the incinerator in a closed tight bin. After the procedure, instruments will be placed in a dedicated biohazard container plastic bag inside the operating room before sending them to the central supply. Central supply staff will receive the used instrument with universal precautions and proper PPE, wearing proper PPEs. Instruments will be washed 3 times cycle in the auto washer with water and detergent and the approved chemicals. Used biohazard bags will be placed in a separate bucket and will be disposed immediately with precautions. Sharp items like blade, needles will be placed in a separate sharp container and disposed accordingly. I'll give you an example. A young female with acute cholecystitis came during this period. She did not have any clinical evidence that she has COVID-19, but workup showed her to be COVID-19 positive. She was treated with antibiotics and kept in the COVID-specific area in the hospital. She responded and was subsequently sent home. At home, she had repeat attacks. 6 weeks later, her COVID PCR was negative, but she still did not have COVID-19 antibodies. Her HRCT was negative, so she was declared that she has cleared her infection, and even though her antibiotic status was still not positive, and she underwent the cholecystectomy. Now, there are other conditions besides emergencies which require urgent treatment. So cancer and other non-emergent but life-threatening conditions were catered. Patients were evaluated on case-to-case basis and operated following a laid-down protocol. So in summary, I would say that a specific protocol has to be followed. Personnel taking care of the patient should wear full PPE. Same personnel should be allocated to a single patient for all different phases. Once the patient is inside in the operating room, there should be no staff transit, movement of the staff from in or out of the operating room. Patient, while moving in the hospital, fixed paths should be used with using the shortest possible route away from where the public is coming and going. And the lifts on all the passage should be sanitized properly, especially if there is material like vomitus of the patient, patient vomits in the lift or something like that, and set up a waiting area for patient admitted to the ER before transfer to the OR. Similarly, the materials should be replaced before starting each procedure, using dedicated trolleys and metal basket, but trying to keep this number to as minimum as possible. Patient should go directly to the operating bed and quickly to the operating room. He should not be moved to the recovery room at the end of the procedure, rather should go back to the corona ward or COVID-19 ward or designated ICUs. There should be a dedicated OR, and once the patient enters the operating room, the door should close with a clear alert sign on the door. Material replenishment by PPE equipped personnel from outside the operating room. And in these operating room, the one we are using, as I said, has a negative pressure, but in general, a high rate of air exchange in which at least 20 exchange cycle in which 25 exchanges an hour are taking place should be used so that all the material is removed. And this is more especially important where orthopedic emergencies are being done, where there is, when a drill is used, there is a lot of patients' fluid and material goes into the environment and atmosphere. Dedicated stretcher, dedicated ambulances should be used, and these dedicated devices should be sanitized after each use and each potential high viral contamination. During each phase, PPE change must occur following predetermined procedures. Each surface and electromedical device must be cleaned following predetermined procedures. Safe and defined protocols be used to dispose the material. Emergency surgery cannot be ignored, avoided during a pandemic, threatening life. Similarly, conditions threatening limb or organs need to be dealt with. Think that every patient coming in the emergency room is positive unless proven otherwise. Although number of cases, COVID-19 cases are declining, still we have to take precautions. We have to remember that a good surgeon knows how to operate. A better one knows when to operate, and the best is the one who knows when not to operate. The current status of COVID-19 in Pakistan is decreasing. On August 14, that is 2 days back, we only had 500 new cases reported, and I hope this number keeps going down. Now, the other topic that was given to me is to talk about when to resume elective surgery. As of today, in principle, I feel safe to recommend that all elective surgeries and related activities can be resumed with proper precautions, following protocols, getting a COVID-19 PCR preoperatively. American College of Surgeons has laid down a very well thought of pattern as to when to resume elective surgery after a pandemic, and that is to look at the facilities, capabilities, and capacities. If you think they are compromised, then there's a definite pathway that has to be followed. But if you think the capacities and capabilities are not compromised, then you proceed with normal operations and maintain COVID-19 surge plan. If you think the activities are compromised, then elective surgeries should not be done. If the surgery is essential, then try to delay or cancel the case. If it requires to be done and patient has high symptoms, then try to do the surgery and discharge the patient. But if the patient requires to be admitted, then predict the resource utilization, ICU admissions, need for special nursing facility. Look at, evaluate the patient according to their ASA classification. If they are in ASA 1 or 2, then proceed with surgery with inpatient admission. If they have risk factors, if they have risk factors, or if they are in ASA 4 classification, then delay or cancel the procedures. So with this, I come to the end of my presentation, and I'll be very happy to answer to any questions that you people have. Thank you.
Thank you, sir. That was a very wonderful presentation. Thank you for your valuable insights. It's been a wonderful learning experience. So I'll begin the question and answer session with the first question. So So, sir, have there been a significant backlog of patients awaiting surgery due to the current pandemic?
Oh, definitely, absolutely. There are a lot of patients, quite a few that we had told them to wait, and there is a significant number of patients who did not come to the hospitals because of the fear of COVID. And unfortunately, we see them and we see that the disease they had progressed to a point. Say, I could think of a couple of cancer patients who did not come to the hospital, and their disease has progressed significantly in these couple of months. So yes, we have a backlog of patients, and we are seeing patients coming to us with a little advanced diseases.
Okay, sir. So the next question is, are there any significant difficulties in performing surgical procedures due to the amount of PPE that you are wearing during the procedure?
Absolutely. It is very hard. I think if you have to, wearing all those protective gears, I'm glad we had despite good air conditioning, it was very difficult. And if the procedure is prolonged for more than an hour, it was hard. But I guess being a doctor, you have to do that.
You have to get through it, exactly, sir.
Mm-hmm.
Okay, sir. So there's another question which has come in. So doctors have used all sorts of cares and sort of measures to prevent contracting COVID. But after a certain time, there are some instances where doctors do contract COVID-19 in isolation areas. So why do you think that is, sir?
Well, I think you have to remember that despite the fact that we wear all the protective gear and everything, still we get there are patients who are not diagnosed, and we get exposed to them, and they get diagnosed subsequently. We have a significant number of hospital workers, doctors, nurses, paramedic staff who were positive. And I think if, I can't remember the statistics offhand, but the number of hospital staff getting is very high, like 20-30%, which is higher than the average population. This is, if you are asking me about the exact cause, I think it's very difficult to be completely germ-free environment.
Of course.
Mm-hmm.
Okay, sir. Now, considering the amount of staff and the amount of nurses and everything, the amount of people that are required to actually have the personal protective equipment, are there any significant logistical challenges that you've had to face ever since the pandemic has started?
Well, as I said, initially there was an acute shortage, and we were, but I think luckily with the involvement of different organizations, especially organizations like yours and other people, volunteers, the equipment and protective gear was made available. And I'm proud to say that most of the hospitals, there might be some underutilization, things were present in the stores, but most of the places where it was required, the PPE and stuff was made available. You have to remember that there were reports in media that there are a significant number of people who were not getting the complete protective equipment. But if you have to provide that to everyone, then of course it was difficult. You had to cater to the needs and provide it to in the places where the exposure was more. Say like in emergency rooms and all that, especially OPDs or centers where they were looking at flu-like symptoms. So those are the areas where PPEs were required, and I would say they were available in most of the places.
Okay, sir. So I'll move on to our next question. In case of a COVID positive patient in need of emergency treatment that cannot be postponed at all, what extra precautions are taken by surgeons?
Well, as I said, that if every patient coming in the emergency room, you have to presume, proven otherwise, that he is COVID positive. You have to, all the people who are taking care of him, they have to wear protective gear. If the patient has to go to the operating room as the condition that you are specifying would require, then, as I said, he has to be taken to the specifically designated operating room where you have negative pressure, where you have got designated staff. You operate on them using all the protective care, make sure there is very little extra movement of staff there. Once the procedure is done, then you recover the patient in the operating room instead of taking him to the recovery. And once he has recovered, then you go to the ICU room or to the designated room which has been specified for COVID-19 patients. And you take all the precautions. But then you disease as accordingly.
Yes, sir, understandable. Sir, another question, more on the anesthesia side. What protocols did anesthesia take while intubating patients?
Well, I think, as I said before in my presentation, the anesthetist is the one who is most exposed to the virus because of intubation, and they would wear shields. They would wear special masks. I mean, not the ordinary masks that we were wearing, the special masks which were protective. They would wear gloves. They have to cover their neck to make sure that this protective PPEs that they wear, somehow the other neck is one area that gets left exposed. So that area needs to be covered. Unnecessary procedures like, say, let me just give you an example, in laparoscopy or in cholecystectomies, we like to have besides doing an endotracheal intubation, we like to have an NG tube placed. Okay.
Yeah.
Now that, I think, in a situation like COVID-19 during COVID-19 pandemic, we have tried to get away with it. We have tried to do cholecystectomies without having NG tube placed, just to protect our anesthetist from getting exposed to the extra load of virus. Because we know that it's not only the presence of virus, but it is the viral load that also matters. And if you are doing procedures in which airway is exposed, or you have to do a tracheostomy, then the person performing all these procedures get an extra viral load that can be more harmful.
Of course, it's quite dangerous then. Sir, on similar lines, why weren't the ASA-4 patients operated upon exactly?
ASA-4, see, you have to remember ASA, this is ASA-4 means that this patient, if not operated, is going to die within the next 24 hours. So if you have, this is just like emergency situation triage, where if you have 3 patients who are dying or who have a disease and who require intervention, then you try to divert your resources towards the patient who has more chance of being saved, as compared to diverting your resources to a person who has very little chance of surviving.
Of course, sir. Sir, now another question is regarding the technological advancements in our current age. Are you more inclined towards robotic surgery instead of open surgery to limit patients and doctors from exposure to COVID or any future diseases that may occur?
I think robotic surgery is coming in. Basically, definitely in situations like pandemics where the operating surgeon is going to be exposed to it, robotic surgery can make a big difference. But then you have to know that this is not something that you can jump on. You have to gradually develop your facilities. I mean, cost of robot is very high. The there are very high finances that are involved with it. There is very high maintenance that is involved with it. So, in an ideal conditions or in a perfect financial conditions, it would be the best thing to do. But I guess we have, it's a long way before we reach that age, reach the time where robots would be replacing the surgeons. So I think surgeons and anesthetists and hospital staff will still be exposed to these infections
for a very long time. Okay, so there's another question from Mr. Iqbal Haider. What are the recommendations for UV radiation in the operating theater?
Well, I think I am not so sure if UV, UV lights take a fairly long, they are very effective in decontaminating or cleaning the hospital or environment. They should be used, but I think the chemicals that are being used, I think it's silver hydroxide that was being used, and other chemicals to wash the surfaces, as well as the sprays to clean the environment. So I think all these things are good, and they can supplement one another.
Okay, so it's like a bunch of different methods which will help decontaminate the OR, of course.
The idea is that contamination is removed, irrespective of the method that is preferred in a specific hospital.
Okay. So there's another question. How did you separate the patients in the recovery room?
Sorry, as I said before, if you suspect that a patient has COVID or he has COVID, as in my presentation, as told you also, that patients are not taken to the recovery room. They stay in the operating room, they are recovered in the operating room, and then they are taken directly to the COVID designated area in ICU or in the floor, but not to the general recovery room.
Okay, that makes more sense. Sir, what is your opinion on permission for final year medical students to be allowed in the OR during this pandemic?
Well, I think that, as I mentioned earlier, that the number of people should be kept to a minimum. And, anyone who is not, I remember doing a couple of cases, COVID positive cases during this pandemic, and we had problems because we had told the personnel that we need less number of people. So we had to the required assistance was compromised. There was less circulatory staff, but the requirement is such that you keep the number to minimum. So I would recommend that final year students, in a pandemic like that, where they are just going to observe a procedure, should stay away from the operating room.
Of course. So this question leads to another question that somebody has asked. How did you decide on the amount of people in the OR? How did you limit the amount of people in the OR?
We say if you have 2 circulators in a given operating room, you cut the number to 1. It depends upon a procedure. If you are doing a procedure in which you require only 1 assistant, and the scrub nurse or the scrub nurse can perform that, then it's like a simple procedure like an appendectomy, then you don't get the assistant. But if you are doing a procedure in which you really need an assistant, or you need more than 1 assistant, then of course you ask for it. So that varies from procedure to procedure. Okay. But the objective or the principle is this, that try to keep the number to as low as possible. And that varies from case to case.
Understandable, sir. Sir, what about post-surgical patients, if any, who have acquired the virus? What are their outcomes as compared to the non-infected post-surgical cases?
Well, I think you have to remember that besides the routine surgical complications or outcomes that happen due to a disease, the patient also has COVID-19, then they are at a higher risk of having pulmonary complications. They are at a higher risk of having complication related to thrombosis and stuff like that. So, these things have to be kept in mind, especially that they could have compromised pulmonary function.
Compromised pulmonary function.
Their lungs might be compromised.
Yes, sir. Sir, sticking to the theme about all the different types of maintenance systems that are taking place in the OR due to in the pandemic, what specifically was done with the ventilation system in the OR?
Well, as I told you, I mean, that ventilators have to be, if you suspect, I mean, first of all, every patient, every time you use a ventilator, there are things in it which are disposable, like tubes and all that stuff. That is discarded anyway. But if you are exposed, if your system exists, your ventilators or that are exposed to a patient who was COVID positive, then you have to take extra steps to clean and disinfect them so that this disease is not transmitted to the other patient. So proper cleaning and sterilization of equipment has to take place. And as I mentioned earlier, that use as much disposable material as possible so that you can get rid of them.
Get rid of them. So, Dr. Aisha Khan asks, for future ophthalmologists, what would be your recommendations regarding eye surgeries as we are very close to the eyes and at high risk transmission? Also, how should we be able to examine the eyes without risk, in your opinion?
I think, you have to understand that first of all, there is, I mean, I'm not an ophthalmologist, but there is a very good newer equipment that's available. Just like you mentioned robotic surgery, similarly, you have got very good cameras available that can look inside the eye without getting close to the patient. And if you could do that and get all the required information, then that would be the ideal thing to do. But in case you are stuck, you don't have that kind of equipment, then please make sure that you are wearing proper shields, proper goggles, covering yourself, and making sure that these things are changed immediately after you have seen the patient before you go on to see the next patient, not only to protect yourself, but to protect the subsequent patient that you will be examining. But if you can sorry, go ahead.
Sorry, sir.
No, get hold of special equipment which can record what is going on inside the eye without getting close to the patient, then that probably would be the perfect thing to do.
Perfect thing. Sir, while sticking on the theme of ophthalmology, like there are different sort of surgical fields, of course. So in each different surgical field, are there any special requirements in terms of personal protection during the surgery, or is it like the same throughout?
Well, no, as I said before, that yes, the requirements are vary from field to field. Like if anesthesia people, they require extra precautions, extra equipment. Similarly, if ENT surgeons, they require extra precautions. Orthopedic surgeons, they require extra precaution because of the fact that all the fluids and body tissue is dispersed in the atmosphere while drilling of the bone is being carried out. So yes, the requirements do vary from specialty to specialty, and steps should be taken accordingly.
Okay. So now, kind of sidelining towards the academic point of view, what are the current topics which should be focused on to research related to COVID-19 in terms of surgery?
I think there is a lot of material available. People are, some of the things that we haven't. You asked me one question initially, that what are the complications that, if the specific complication rate was higher in patients who had COVID-19, and I said one has to especially look for pulmonary complications. But I think individual institution might not have enough data. And I think if we collect our pool and then compare the results that we have seen, then these would be a good research topics, especially from surgical point of view. Prevention steps that you take to prevent would be an important research topic. Financial impacts, psychological impacts, that would be important. Similarly, complication rates occurring in patients who had COVID, that would be important. The effects that it has on surgeons on healthcare workers, the effects, not only the viral effects related to viral infection, but also the mental effects or the effects, environmental effects. Wearing a mask, special mask all the time, getting a little CO2 retention by the hospital workers because of the fact that they are wearing, all these things can make a good research topics or research activity for young doctors and students.
Okay, sir. That was a wonderful question answer session, sir. And thank you for answering all the questions. It's been a wonderful learning experience. I'd like to conclude this question answer session by handing it over to Dr. Mavish. Thank you, sir.
Thank you so much. Thank you so much, Professor Mussadiq. It was really very insightful. I do have one personal question, though. For some of us who want to pursue surgery, what guidance would you give us, particularly keeping in mind the pandemic and the limitations we are currently facing?
Well, I think if someone wants to pursue their career in surgery, I don't think this pandemic should come as a hurdle. I mean, if you want to become a surgeon, you want to become a surgeon. I mean, these pandemics come. Similar hardships will be coming in future also. But a person who wants to pursue the specialty of surgery, they will do that, and I welcome them. And I think it's a nice specialty to follow.
Yes, definitely, sir. Thank you so much, sir. It was such an honor to have you on board. And we're also grateful to you, particularly one of our co-founders for VFP, Dr. Abil Tariq. She is particularly grateful to you for treating her mother about 20 years ago. And she still remembers to this day.
Thank you very much. That makes me feel very, very sure it's amazing that I have patients who come to me and they say that you had operated on my grandmother, or you had operated on my mother and father, and I've been around for a long time. Thank you.
Thank you so much, sir. We would now like to take a short 5-minute break before we announce our second speaker. Thank you again, Professor Mussadiq, for joining us. It was really an honor.
My pleasure. My pleasure.
Thank you. Ladies and gentlemen, welcome back to our session. I'm honored to announce our second speaker for tonight, Dr. Javed Raza. Dr. Javed Raza, a consultant surgeon, director of bariatric and metabolic surgery at Cleveland Clinic, Abu Dhabi. He's also the vice chairman of a medical charity, Midland Doctors. They have constructed and are running a 90-bed charitable hospital in Muzaffarabad in Azad, Kashmir that provides free medical and surgical treatment to poor and needy patients. Dr. Raza graduated from COVEB Medical College, Peshawar in 1988, and after initially training in Pakistan, he also trained in Ireland and UK. He completed his fellowship from Royal College of Surgeons in Ireland in 1996, a fellowship in advanced laparoscopy and laparoscopic bariatric surgery from Liverpool in 2006, and later intercollegiate FRCS in 2008. Dr. Raza has multiple center multinational training in advanced laparoscopic and bariatric surgery from UK, Netherlands, and California, USA. He also has an experience of developing 4 bariatric surgery centers in Abu Dhabi, as well as in UK, where he was also a part of a group to develop bariatric surgery guidelines. He's an author of 4 book chapters on bariatric surgery and published numerous articles in peer-reviewed journals. Dr. Javed has performed more than 1,200 laparoscopic bariatric operations and has been a trainer for advanced laparoscopic and bariatric surgery in both UK and UAE. Other areas of expertise include surgical treatments of esophageal and gastric cancer, laparoscopic cholecystectomy, CPD exploration, laparoscopic hiatal and diaphragmatic hernia, laparoscopic abdominal wall hernias, and laparoscopic treatment of small intestine disorders, including small bowel obstruction. Through his work, he was involved in media in UK, where he appeared on regional BBC and a full program on Channel 4 about bariatric surgery. Dr. Javed has provided training to surgeons in Egypt and Saudi Arabia, provided live operating for courses, run training bariatric courses in UK, and shared multiple sessions at international meetings in Kuwait, Saudi Arabia, Egypt, and UK. Thank you so much, sir, for joining us. It is such an honor.
Thank you, Marish, and thank you to Ventilators for Pakistan. It's really heartening to see that not only the educational activity that is you've started, but also the wonderful charitable work that you shared some slides. And as we spoke over the phone a few months ago, I think more and more young people coming to the charitable side and on the volunteer side, it's Pakistan has a bright future, and I'm very heartened by it. I just want to sort of add, you've been very kind and generous in your introduction, but I'm also involved with charitable work, and we are running a charitable hospital in Muzaffarabad, Azad Kashmir, and we started about 14 years ago, and we provide completely free healthcare to patients, including operations. And so far, we have treated more than 350,000 patients and provided them medication, labs, x-rays. And I've been involved with training bariatric surgeons in Pakistan. And I think in my talk, we'll make some references to that. I think your organization, I've been liaising with Dr. Sabakhtar and your other co-founders, and I think it's very heartening and encouraging to see how people are responding to the challenges that our nation has. Mashallah, doing a great work.
Thank you so much, sir. Those words really mean so much to us.
So I have loaded my presentation, but I also have a second presentation, where while we're talking, I work in Cleveland Clinic, Abu Dhabi, and fortunately, it's a resource-rich system in UAE, and there will be, I think, a lot of things may be directly applicable to Pakistan, but I'm very aware of the situation and the resources in Pakistan because I am part of a charitable setup in Pakistan. But I think it's always useful to know if the resources permit, then what can be done or what should be the standard, although being mindful of limited resources that we have in Pakistan. Okay, so I'll make a start.
Yes, sir.
And I don't mind, I want to keep it informal, so I don't mind if there are questions that I need to answer during my talk, and if there are any questions, and if someone has a burning question during the talk, then I'm very happy to stop and answer those questions.
Okay, sir. Thank you so much.
So I think we in UAE, where I work, we are a few months ahead of this curve of COVID, and we have passed the peak, and we are well back into our routine elective work. So I did this talk about 2 months ago, first for an international group that was across Europe and across the Middle East. And when people were thinking about when they would start, SAGES, which is Society of Gastroenterology Surgery in US, they did a seminar on this very topic. So I've incorporated some of that. And broadly speaking, when you're thinking about reopening the hospital or restarting your elective activity, the factors would be related to the patient, your staff in the hospital, and your resources, which is your equipment and instruments that you need for your surgery, and then the hospital environment. So broadly, these are the 4 factors which would determine how much and how soon and how effectively and how safely you can resume elective surgical services. So as I said, SAGES and European Association of Endoscopic Surgery, they are the 2, I would say, the largest collaborative bodies for laparoscopic surgery and GI surgery on the planet. So they had a joint symposium. So I'll incorporate some of that. Cleveland Clinic Abu Dhabi has been the leading hospital in our region to not only treat the COVID patients, but what to do post-COVID and how to transition into post-COVID situation. And I've looked at some studies which may not be directly COVID related, but are very pertinent to our talk. So the basic principle is that it has to be a gradual return and a well thought through process. We cannot decide one day, okay, like the situation is in Pakistan, there are a lot of hospitals, especially private hospitals, where elective activity was either stopped or significantly curtailed. And the main source of income for many people was that elective activity, and the financial priority tends to push and let the clinical priorities take a back seat. So it is important to think it through, because the price by doing it too quickly or too much may be too high for the staff and for the patients. So if you, and there as Professor Mussadiq Saab said, there are patients who would require urgent or emergency operations, and you cannot wait for the COVID to finish. So in that setup, for patient safety, if you're going to do elective surgery in a hospital which still has some COVID patients, then there needs to be separate protocols, pathways, and physical areas within the hospital. The staff should have adequate protective gear. They should have training during COVID as how to deal with elective work, and very defined roles. In terms of timing, when the disease is going up or at the peak or when it's coming down, if you restart too soon, you may end up having a second peak, and this has happened in Europe in several places, and now in some of the states in US. And if you restart and you feel that it was premature, then be prepared to accept that it was not the perfect timing and take a step back and sort of park your ego and look after the best interest of the patient and your staff. So I think in Pakistan, we are where we were in UAE about at the beginning of, I would say, June. And things are looking good. The infection rates are going down. The mortality is down. And now everyone is thinking and getting ready to get on with the elective activity. So I'm talking purely about elective activity. That's why I'm not going to talk about emergency or urgent operations. That's a separate topic, and they should be dealt with on their own merit. If, let's say, when I say surgery, I mainly talk about laparoscopic surgery because that's about 95 to 97% of my work. And most of the modern general surgery, abdominal surgery in most of the places around the globe is now laparoscopic. In Pakistan, it is picking up as well significantly. So if there is an elective lap chole or a hernia and the patient has COVID positive test, then please do not operate on these patients. I will show some data from China which shows the mortality and complications is very high. If you're going to start elective activity, make sure that you have enough protective gear for yourself, for your staff. And staff does not mean anesthesia, nurse, and a doctor. Staff also means your cleaners. Staff also means people who are going to look after the other needs of the patient, and people who are going to be in contact with patient throughout their journey, including your security staff. You must plan for the most smooth transition in and out as efficiently, as effectively as possible whenever you start, when you start this elective activity. I know that in Pakistan, the communication with the patient in terms of the informed consent and the risks of surgery is quite limited. And a lot of times, patients who are not educated may not want to know a lot about the surgery. But in West, and especially in UAE now, we routinely, when we are discussing the risks of surgery, we always mention the additional risks from COVID-19. Although we are a COVID-negative hospital now, COVID-free hospital in Cleveland Clinic, but part of discussion of COVID-related risks is still part of our consent form. So I would recommend that whenever you're thinking about elective surgery, this should be part of the strategy. And if you feel that there is some doubt about either patient's status or has new symptoms, then please don't hesitate to cancel the operation even on the day of surgery. It may be a disappointment, but it will be safer than causing harm to the patient. If for elective activity, it is mandatory that every patient who either has an endoscopic procedure or a surgical procedure should have a PCR test for COVID. Our routine in Cleveland Clinic is that the test is done 48 hours before surgery, and then we ask the patients to isolate at home after the test. Now, this is not 100% safe method, but this is as close practically as we can get. The usual turnover time for PCR is about, for the routine test, is about 8 hours to 24 hours. There are two new types of PCR tests, and we have fortunately one of them or both of them in Cleveland Clinic. The most expensive one can give you a PCR result in 1 hour. And it is about 5 times more expensive than the standard 24-hour test. But we use this for patients who come to our hospital currently with acute conditions like appendicitis or perforated viscus, and they need surgery. So we can pretty much turn around within an hour and know the status of the patient. And if they are positive, then we take all the precautions, and I'll make reference to that a bit later. I think most of the places, including Pakistan, most of the people have mobile phones, and the facilities to communicate online have tremendously improved. We took advantage of these facilities in our hospital in UAE, and we, when we were at the peak of the COVID, we used to hold video consultations with our patients, even for our elective work, and we minimized the patient visits to the hospital. We also asked the patient to keep log of their temperatures and gave them the quarantine instructions as part of the video education. Different hospitals would have different protocols, but I would suggest that if you are thinking about elective activity, even though the number of cases in Pakistan is low, many patients, I know that the testing is very low in Pakistan, so I would not rely completely on that, and I would suggest that every patient should have a PCR COVID test prior to any elective surgery. There is serology testing, chest X-ray, CT, blood test. I don't think any of those are validated tests, and PCR remains the gold standard so far. So when the patient, let's say we have a patient who has gone through the check and no fever, and suddenly on the morning, and this is a patient, this is what happened last week on my operating list on Monday. The patient was for repair of a large hiatus hernia, and he came and had cough and fever. The fever was low-grade fever, but he was sneezing, and it may be a regular viral infection, non-COVID viral infection, but we explained to the patient and we did the COVID test, and we postponed the operation. And the patient is going to have a further test this week, and if all the symptoms are settled, then the patient will be rescheduled for surgery. So this is from patient's point of view. What about the staff? We get random testing. Some centers have applied testing for all the staff. We had testing of all the staff once, and randomly people are checked for COVID even if they're asymptomatic. This is just a quality control to make sure that as caregivers, that's what we call ourselves in Cleveland Clinic, we do not pass the infection to patients and do not cause any harm to our patients. So this is a study from China, and this is just at the beginning when COVID was becoming a known entity. So the patients who, this is the Chinese paper, so the patients who were found to be COVID positive and had operations, they compared them to patients who, similar patients who did not have COVID, and what were the difference in outcomes. So out of the patients who had who were COVID positive and had surgery, 44% were admitted to ICU for a range of operations, and similar surgeries in non-COVID patients, only 26%, the patients who had COVID but were similar attributes, only 26% were admitted to ICU. So just by having the surgery, there's about 18% increased risk of requiring ICU. So level 3 operations, which is like a colonic resection for cancer or gastric resection for cancer, 13 out of the 15 patients went to ICU. The requirement for ventilator for these operations with COVID was 33%, and 6% required ECMO. ECMO is a very rare facility, even in big centers. So the mortality for someone who had COVID, which was not known at the time, and had surgery, was 20%, compared to 1 to 2% of these patients who had COVID, similar patients, but did not have operation. So just by having surgery increased the chance of dying about 10 to 20-fold. So if you have COVID, then please do not offer elective surgery. And the symptoms of the COVID, if someone who had COVID and had surgery, the symptoms manifested and accelerated quickly after surgery, whereas the same patients in a similar sort of comorbid conditions, if they did not have surgery, then their symptoms were milder. So the simple message from this Chinese study is, if you have COVID or if you have suspicion of COVID, then do not go for elective surgery. So in an ideal world where you've got a lot of resources, and when you have got a lot of COVID in the country, then assume that everyone has COVID. There should be negative pressure rooms and separate rooms for donning and doffing. I'm sure most of you now know that donning is where you put the protective gear and doffing is when you take that protective gear off. And they need to be in separate areas so that there is decreased chance of transmission of infection. The negative pressure system, and I have operated in a lot of hospitals across Pakistan, and even in bigger hospitals, in bigger public hospitals, there's hardly any ventilation. There's usually an air conditioner. The negative and positive pressure ventilation is the positive is when there is a positive flow, so the air flows from the ceiling of the room, and on the operating table, clean air comes through filters, and then the air leaves out through the doors or beneath the doors outside. So that's the positive pressure. That protects the patients from infection, especially in operations which are more sensitive, like orthopedic surgery, neurosurgery, etc. The risk with COVID patient is, if you do that, then if the patient is COVID positive, then the air leaving the room outside will carry the risk of infection to people outside. So the negative pressure system will be a closed system where the air is sucked out of the room and passed through special filters, which makes it safe to be disposed of externally. This is expected.
I think we're having some connectivity issues with Dr. Javed. Dr. Raza, if you can hear me, you're having some connectivity issues. Your voice is being cut. Sir? I think we've lost Dr. Javed Raza. So Dr. Zaid, what is your insight regarding this presentation?
Well, currently it's quite informative because like previously, Professor Mussadiq had told us about the different like the emergency protocol procedures, like all the protocol that should be taken for emergency procedures. So far, Dr. Javed has been able to clearly outline the different protocols required in elective surgery, and they kind of fall on the same line. And so far, the take-home message is like if it's an elective surgery and can be postponed, then please postpone it. But if it's not a requirement, then there's no need to do it. What
Yes,
do you think so far about it?
that's entirely true. And it's actually scary because a lot of people who were not COVID positive previously underwent surgery and did contract the virus, and most of them did pass away. I know a lot of friends, fathers who passed away because of that. So it's something that we are going through. And I think participants were just working on getting Dr. Javed Raza back online. He's just shifting his Wi-Fi. So we'll be back in a minute.
But this whole talk about how the surgical field has affected, I think we got Dr. Javed back. Yeah.
Yes, he's back online.
Sorry about this. I think
No problem.
I heard that I was talking and I think the connection was lost. Can you hear me okay now?
Yes.
Okay, we'll go back. Practice in our hospital when we had active COVID patients was that the room was, after a COVID case was finished, the room was cleaned, and then we left. Can you still hear me?
Can I interrupt you for 1 second? So can I interrupt you for 1 second? Can you please load your PowerPoint presentation again?
Okay, is it not? Okay, maybe I need to go to the share thing again, yes?
Yes, sir. Share screen.
Sir.
Okay, can you see it now?
Yes, sir. Now it's coming up.
Okay. So during COVID, when we performed operations on COVID patients, the number of cases was significantly reduced because between the cases, the room air needed to be all cleaned, and we waited even after the patient was intubated, and the anesthesia staff had a full protective gear. And then there would be 20 minutes before the surgeon would enter the room to allow all the airborne risk of infection to settle down. So there was a significant change in protocols in terms of who enters the operating room when and who wears what. And between cases, there's deep cleaning. So a lot of, we fortunately were able to have these resources. So we followed a lot of these protocols, but not many hospitals in the West. I was on a live webinar with doctors from Germany and Austria, and they did not have those facilities. So don't feel bad if you don't have those in Pakistan. So this is, on the left is our doffing room. You cannot go in and put on your protective clothing here. This is just to take it off. The room needs to be of a sufficient size and enough facilities inside the room. We actually had separate lifts for the COVID patients. So this is a picture I took about two and a half months ago when we had many cases. So the patients were transported through separate lifts, and separate pathways were identified within the hospital for COVID patients. This is what we routinely used for our surgery, even in non-COVID patients. We had the N95, the hood for the head, and the face mask. And this is the pepper, which is if you are operating on or doing a procedure on a known COVID positive patient, then and I have a short video which basically, I had a patient who came in with bleeding after surgery from outside, after bariatric surgery, and the patient needed, it was endoluminal bleeding, so the patient needed an upper endoscopy to find the source of bleeding. And this is first time when I had to do this, so I made a video and I then asked my son to edit it. So shoe covers, and then the hood, and then that's the first pair of long gloves that covers half of my forearm, and then goes the whole body suit. And if you can see on the left is the place where there is a designated nurse whose sole job is to help people get prepared for a COVID case. And then I'm being checked for any possible areas where an aerosol infection can get onto my regular hospital clothing. And then goes the second pair of gloves. And again, and then there's a waterproof covering that goes on top. And this was endoscopy. And now I've got, this is the pepper. This is the system that provides a hood which covers my head and face and has a motor at the back that provides clean filtered air for me to breathe. And then a tubing attaches that motorized part to the hood. And then the final gloves. This was an endoscopic procedure, so I did not need the sterile gloves. Otherwise, I would be wearing sterile gloves. And inside the same patient, because for endoscopy, normally you give sedation, but in COVID times, it is safer and better to do endotracheal intubation and give general anesthesia because you control the environment of the patient. They're not coughing and sneezing while you're doing the endoscopy and you're at less risk. So this is how my anesthetic colleague was actually giving anesthesia. And there was a question earlier on about the precautions. So if you look at my anesthetic colleague, so they're wearing the same sort of protective gear. And I don't know if you've noticed, they used a video laryngoscope here, just behind this man. So the anesthetist is not peeping inside the patient's mouth. They are looking at the monitor. So that in turn decreases the risk of the vapors from the patient and the risk of COVID. And this is just a picture. This is the patient, anesthesia. That's me, and that's my nurse, and that's the anesthetic technician. So everyone has got the protection. So this hood that I was wearing is called Pepper. It is air purifying respirator and uses a blower that forces the air through the filters which are on the waist and canister in the breathing zone of the wearer. So I get fresh air. This is actually better than wearing a face shield, because with face shield, it keeps fogging up and you can't see. Pepper is used when we are either treating a patient with a known positive diagnosis or where there's suspected diagnosis. This is re-sterilizable, so it can get sterilized and reused many times. And then it has about 4 hours cycle of during which it can be re-sterilized. So this was the sort of an ideal situation where resources and willingness of the leadership to spend money on those resources is not an issue. In reality, every hospital, even in UAE where I work, not every hospital here had the same facilities or the resources. And every hospital will design their own protocols regarding the operating rooms and how you utilize them and the use of your protective gear. There are standard precautions that we all take for surgery, irrespective of our COVID status. And then there are transmission-based precautions, which are because of the droplets or virus in the air after patient coughs or sneezes, or which you get from direct contact from the patient. So this is a paper that looked at the risk of surgical smoke, and this is now we're talking about laparoscopic surgery. So when we do laparoscopic surgery, we often use diathermy or other energy sources, and which generates a lot of smoke. And there is currently, there is no evidence that COVID-19 is transmitted excessively with laparoscopic surgery. At the beginning, all laparoscopic procedures were stopped according to SAGES, but later on, the advice was to carry on with appropriate precautions. So in Pakistan, where we don't know who has the disease and what is the quality of the gear, I would recommend that it is taken under extreme precautions, and every surgeons must insist that the patient has a valid COVID test for elective surgery before they expose themselves to surgery. This is a study where they looked at human papillomavirus for surgeons who are doing anogenital surgery, excising those lesions. Many years later, they developed a squamous cell carcinoma in their oropharyngeal cavity. Now, this is the smoke that they inhaled resulted in transmission of virus from the patients onto their upper respiratory tracts, and then years later they develop carcinoma. So there is a theoretical risk of similar occurrence in COVID-19. So we started using smoke filters. For laparoscopic surgery specifically, there are smoke filters and smoke evacuators. The difference is evacuator is a system which you attach and it sucks the smoke out, puts through its own filter system and makes it safe. Smoke filters are small things that you can attach to the ports and the smoke comes out going through that filter. Special consideration during laparoscopic surgery, let's say you're doing a laparoscopic cholecystectomy and you've done it, and at the end, when you remove the gallbladder, either in a bag or without a bag, you simply pull it through the 10 or 12 millimeter port. Now, what happens at that time? The specimen comes out, but also comes a lot of intra-abdominal gas. If it's a COVID patient, then you have exposed yourself to that. And the advice is that you desufflate the abdomen, let the gas through the smoke evacuator or filter, and let the abdomen collapse, and then you take the specimen out. Same applies to closure of ports. There are several ways of closing the laparoscopic port, and people use the port closure systems where the abdominal cavity has carbon dioxide under pressure, and you pass a suture alongside the port, and that inevitably results in leakage of carbon dioxide to the outer atmosphere, and with that, the risk of COVID transmission from the patient. So the recommendation is that you desufflate the abdomen and close either as an open technique or without the gas or with minimal gas, which is not under pressure. We have a routine in Cleveland Clinic of doing a patient in the operating room a sign-in, which means when the patient enters the operating room, the whole team, that includes the surgeon, the anesthesia, the scrub nurse, and the runners, they all gather. And while the patient is awake, the patient's details and the health conditions are checked, and that is called a sign-in. Second point is just before making the incision, it's called timeout. Couple of details are checked again, the correct patient, the correct site, and it's documented. And at the end of the operation, we have something we call a sign out. Now, let's say you were planning to do a gallbladder operation laparoscopically. So that was the plan of the operation, but you ended up opening up and doing an open cholecystectomy because it was a difficult operation and exploring the bile duct. So the operation that was intended was different from what actually happened. And that's why at the end of every procedure that we perform here, we do a sign out, which is actually what happened, and that is documented both by the anesthesia and the nursing staff. So sign out, with COVID, we have routinely started including the information about the COVID status of the patient. And it is important because when you hand over this patient to the recovery, they need to know if the patient is COVID positive or negative, so that, number one, they protect the other patients around this patient. Secondly, they protect the staff looking after and take the appropriate precautions. So the change in practice is that COVID status should be part of sign in and sign out. So these are some of the other suggestions. Again, someone asked about the anesthesia. So the precautions that our anesthetists have taken is that the most experienced member of the team does the intubation. During COVID, we sort of put the training on hold and did not expose people to unnecessary risks. We also use the video laryngoscope, where the anesthesia doctor does not need to physically look inside the patient's mouth and throat. They can stay behind, stay at a distance, and look at the screen and put the tube through that. There are also hard plastic boxes that you can cover the patient's neck and head, which has got two openings, and you can insert your hands, and therefore the riskiest part of the anesthesia is when you intubate the patient or when you extubate the patient. And you can decrease that by covering, just like it appears in this picture. And when the surgeon should come into the room, during COVID, the surgeons did not enter the room at the time of intubation. Once the patient was intubated and secured, it gave another 10 to 15 minutes before the surgeon would enter, because the surgeon would use a N95 and a face shield, but not the PEPA that I showed you earlier. Include COVID in timeout. Medical students, we stopped during the COVID. We have in Cleveland Clinic, we have a lot of people who come from other places for observership and for short attachments. And again, I think once COVID is over, I would encourage all of you to try to come, and I'll be very happy to assist in any surgical attachments for people who want to be exposed to to a modern healthcare system. We reduce the unnecessary equipment in the room. We only have what we need, and it's mostly parked outside the room so it can be brought in. Foot traffic is decreased, and we tend to keep the staff throughout the procedure rather than giving staffs breaks. And when we're planning the operating capacity, we put less cases because the operating room needs to be cleaned and given time in between for the air to settle. Again, I have demonstrated through my short video what COVID, that you have to assume when the COVID load is high, that everyone has COVID, wear N95, surgical mask, eye protection, shield, double gloves, shoe covers, and yes, shower at the end of the day. So what else we changed? Our practice in Cleveland Clinic was that in our preoperative area, the relatives would come inside the holding bay, where each patient was allocated a bay. And I will show a video in my next slides. And the relatives stayed with them until we took them for operation. We changed that, so we stopped the relatives from entering the preoperative area. And our routine is that after we finish the operation, we go out and speak to the family about the operation. We changed that practice and we started calling the patient's relatives rather than speaking to them in person. Post-operative visits we reduced. For bariatric surgery, majority of, especially laparoscopic bariatric surgery, majority of the patients that we operated during the last 2 months, the post-operative, they would take a picture of their wounds if there was any concern. Otherwise, the first consultation will be on the web link. If you can do most of the overnight, minimize the hospital stay and do the day cases. And we ask the patients not to mix with their family too much, although that is something we haven't been very successful because of the social norms here. But we advise the patients not to mix with other relatives who may have COVID, and it may affect their outcome adversely. So the message is, as keen as people are to start the elective activity, protect yourself, protect your patients, and be very, very vigilant. Every hospital and healthcare system will have their own resources and their own protocols as long as you stick to the basic precautions and safety measures. So I just want to finish this presentation, and I've got a couple of videos on how my hospital changed and how and you can think of the questions in the meanwhile while these videos are playing.
Yes, sir, we do actually have a few questions that the participants have asked.
Sure. Do you want me to stop here and answer the questions?
No, sir, it's up to you. You can continue with the presentation and we can ask.
No, you tell me whichever way is more useful for people who are listening to it. I'm very happy to go whichever way.
Okay, sir, you can start the video if that's what you want, and then we can ask the questions together.
Okay, so it's a series of few videos. So Cleveland Clinic had about 8 entrances for the patients prior to COVID. So when we became active with COVID, we stopped for patients, we stopped all of those, and there was just one entrance which was allowed for the patients, and this was the entrance. So the patient needed to be with a thermal scanner, and then you would get registered. On the left is the registration staff. This was I just walked through the hospital, and this was one level below the ground, and this is where we're coming to the ground floor. of the main entrance of the hospital. And this to the front is our outpatient department. And this is, let's say if the patient is coming for surgery, so they would pass through this corridor and then get to elevators on the left, which would take you to the operation complex. So the building on the gray in front of you is the operation complex. And these are the elevators that will take you to the registration desk where the patients would Now, once the patient is registered and is coming for surgery, so this is the pre-op area where they would come. And as I mentioned earlier, the relatives are allowed to come into this area previously. And now with COVID, we did not. So this is, every patient has their own small holding area where they come and get changed, their consent is checked, their vitals are checked, any allergies, and they wait here until they're taken to the actual operating room. And we changed by not allowing relatives to this area. And then the next part of the journey is once they're ready and they're going into the operating room, this is where I do my bariatric surgery. And this is how the room is prepared during COVID for both from an aesthetic point of view. This patient had the flexible, so these are the monitors for the anesthesia, separate bins for infected material, and this is where the patient comes, and when they get on the table, this is the view they get. And I just took a very short, I don't know if you can see it, video of a laparoscopic procedure going on. This was not a COVID patient, but was during the time when we had COVID in the hospital. And after surgery, this is the recovery area where the patient is taken after surgery, and within recovery we have separate bays, and we have facilities to keep the COVID patients in a completely separate area and not mixed with these general patients who are not known to have COVID or who are not suspected to have COVID. As I said, I feel very fortunate that I work in a resource-rich area. So this is when we went to the operating room in the morning. One of the nurses checked our temperature and provided us the masks, the N95, and the shields to protect the surgeons and the staff. So everyone needed to be checked in during the COVID time in the operating area, in the operating complex. Everyone needed to have a temperature check and given the appropriate gear. And I've already shared this with you, so I don't need to. So I'm going to stop here and take the questions.
Thank you so much, sir. With your permission, I would like to start the first question.
Sure.
We have this question. Have you operated on any patient who was COVID negative prior to surgery, but during recovery they contracted COVID?
So fortunately, we did not come across that situation because of the protocols and the resources we have. As I said, even at the peak of COVID, for emergency surgeries, we have operated on patients who were positive at the time of surgery, so we took appropriate precautions. But no one who was negative turned out to be positive following surgery. So I personally have no experience, and I'm not aware any of my colleagues in Cleveland Clinic have come across that.
Okay, sir, thank you so much. Sir, another question is, you must have surgeries lined every day, and in that case, how often does the medical staff get themselves tested for COVID? Do you think it's recommended to get themselves tested prior to every surgery or every single day? I mean, it must be inconvenient.
I think number one, if you let me share a quick story. A colleague of mine, he treated a patient in emergency who was suspected of COVID, and the patient was tested and then was COVID positive afterwards. The results came after surgery. It was an emergency surgery, so he needed 3 negative COVID swabs before he was allowed to work again. Although he never tested positive, or none of the other colleagues, but he said, so I asked him, where have you been this morning? And he said, I went for my brain biopsy. And I said, what do you mean by that? He said, when they do COVID tests, they go so deep that every time I feel they're taking part of my brain away. So what I'm trying to say is, doing a proper COVID test is a very unpleasant thing. And if you even suggest that you have it daily, then yes, if you don't like someone, then suggest it for them. but but in routine, I think if there are no symptoms, and if you have tested negatively and have not come across a positive patient, then there is no recommendation that I'm aware of, even if resources is not an issue. You have to look at the benefit versus the cost versus the inconvenience. So I think there is a recommendation that in units where there is high load of COVID, there should be periodic COVID testing for direct contact staff. For example, the operating room staff should be tested every month. And this is one of the recommendations, although I have not seen it being practiced anywhere. So everyone in our hospital has been tested once, and then there are random spot checks, and this comes out like you pick a name out of a box and then test them. So this is a Department of Health in Abu Dhabi. They randomly pick up people and say test them, irrespective if they have symptoms or not. And this has been quite effective, as long as you've tested everyone once and then randomly test. I think that has at least worked in our system in UAE.
That's great, sir. I'm actually really familiar with the brain biopsy bit. I did feel the same. But in fact, we heard actually that there are quite a few false positive and negative cases as well. So in such a case, if you feel like maybe the person does not have a symptom, somebody who's supposed to perform surgery, do you still take all the same precautions, or do you take extra precautions? Maybe somebody who might be feeling slightly feverish but has come up with a negative result. What do you do in such a case?
Sure. So are you talking about a colleague who's in that situation or a patient who's in that situation?
Yes, sir. Both, but mostly colleague.
So if it is a patient and if it is elective surgery, then you postpone the surgery. So do not go ahead. Don't think that inshallah kuch nahi hoga, main theek hu. So you must take precautions. Secondly, if it's a colleague, then I think then it's better to protect the colleague and protect yourself without creating a lot of drama, and without sort of going for witch hunting. It is very easy to create that environment of fear, but I think it is your duty. There's only one Bhavish, and there's only one of your colleague, and there won't be another one. So it is your duty to protect yourself as much as you can within your resources. And I think it is my duty to protect myself, not ignoring my patients, but I think after I protect myself, then I should look after my patients. So that is my message. Unless it's life-saving, then it's the responsibility of the hospital to provide the basic equipment. And I've been involved with COVID in all over Pakistan, supporting ICUs in different places. And I'm really very sad that in many places, a lot of doctors did not even have the masks when they were treating patients in emergency departments. And whenever you ask the administration, they would always say, we have plenty. And when you go and talk to the doctors on ground, it was sad to see how few had the appropriate gear. So I think even if you have to buy yourself, that money is the best money you would ever spend to protect yourself.
That's true, sir. Especially when we're coming home to our families, we're risking a lot of people in a way.
Yeah, your
So we have
parents, your
another-
elderly relatives.
Yes, sir. So we have another question. Are there any specific elective procedures which have the ability to generate more aerosols, thus spreading COVID compared to others? And could you kindly tell us again the specific elective procedures which are performed regardless of a COVID-19 positive patient?
So I think any procedures on the oropharyngeal way, so any ENT procedures, any dental procedures, even eye procedures which involves very close contact, endoscopy, upper endoscopy, these are all very high risk procedures. And unless you have the appropriate protective gear, or even with a COVID negative patient, the minimum you must use is N95. That is the minimum, and with a face shield if you're dealing with upper orogastric airway. In terms of the abdominal procedures, the laparoscopic procedures, as long as the patient is COVID negative and you're taking the precautions, we are still, although Cleveland Clinic is a COVID negative hospital, COVID free hospital now, we don't have any elective COVID patients. Despite that, our protocols still involve testing every patient for COVID pre-operation, and during surgery, still take the minimal precautions of N95 mask and face shield during surgery. So there is no evidence at the moment that in COVID-19 negative patients for laparoscopic surgery, taking these precautions exposes you to any additional risk. But COVID is a very sort of developing story. I'm sure 3 months down the line, 6 months down the line, we will have far better data to make assumptions. At the moment, my advice would be keep yourself safe, but don't get paralyzed. We have to carry on working and looking after patients who need our help.
That's true, sir. Very well said. Sir, there's another question. You had previously mentioned during your presentation that the surgeon entered the OR 20 minutes after the patient was wheeled in. Was this patient anesthetized during this time, or were there other procedures also performed for precautions in light of COVID?
So the protocol was if there was a patient that we did not know the COVID status or the patient was COVID positive, then the level of precaution for anesthesia, anesthetic tech, and the nurse who would be in the room would be the highest, which would be the pepper, the hood that I showed you, plus 3 layers, everything that I showed you, everyone inside the room would have that. Once the patient is anesthetized and intubated and tube is secured, then the risk of the patient exhaling the virus that is going directly into the tube goes into our filter system, and hence the risk of vapors going into the air finishes. But the vapors that have already gone into the room, they need to be cleared, and that needs to be, as I said, about 12 to 20 cycles of clean air. So once the patient is intubated and everything is done, the time starts from then, and then the surgeon is allowed 20 minutes after that. The surgeon would not be wearing the hood and everything. They would be wearing an N95 with an additional mask and face shield. So, so this is to utilize your resources appropriately while protecting your staff, but giving a time gap would allow the air to become clean, and anything in the air that came out during intubation would have disappeared by that stage. So it was from intubation to the entry of the surgeon. Nothing else was done in that room, and minimal traffic. Unnecessary people were not allowed to enter the room during that time.
Okay, sir. Thank you. Sir, in your entire surgical career, has there ever been any need to use pepper apart from COVID? And are there any other situations in which pepper can be used?
No, the answer to the first part is no. I actually did not know what pepper was until I heard from people in my hospital that, oh, this patient needs pepper, and I said, what is pepper? And then I saw this thing. Actually, it was very pleasant to use for a short duration. I think any infection, I hope that we do not come across anything else like COVID in our lifetimes that needs us to use this. But for Ebola and similar infections, which are very contagious and which are spread through either direct contact or through droplet or through vapors. So pepper, it has a filter system at the waistband that you have. There's a machine with a filter, and the air entering that area comes through that filter, and that filter has the capacity to filter out even the smallest viral particles. So this is, I think if you have it, it's a fantastic piece of equipment, but it's expensive, it's cumbersome, and it restricts the communication, because with air coming in and your head inside this thing, when you're talking to your nurse who's wearing the same thing, the communication is very, very significantly reduced. In fact, there has been new sign language to utilize within the operating rooms if you're wearing these peppers. And there are a lot of jokes about that as well, but there is actually a sign language for basic communication needs.
Yes, sir. Sir, in fact, it must have some effect on, or some challenges on your visual activity as well. And do you think that has affected the surgical procedures in any way?
I think it has potential to, especially when we're using the face shield with an N95 mask. I find it very challenging for the full face shield, and so we have found ways around that we put tape, sticky tape at the top of your mask so that the air does not leak under your glasses or under your face shield. It leaks at the lower part. I think on one or two occasions I had to stop my operation and get my face shield changed and go out for 5 minutes, because it can become very hot and very difficult to operate. So that's why I think if for elective surgery, unless you're absolutely sure that the patient is COVID negative, do not take unnecessary risk, because all this protective gear does make pose extra challenges in terms of the surgeon's comfort and communication.
Yes, sir, definitely. I'm really baffled by how all of you surgeons are doing all of this in so many layers, particularly. There was also another question. Does the exhaled air, it mix with the clean or fresh air that is filtered in? Is there ever any risk that puts you guys in such a place?
So I think the exhaled air is the one that has come out of your lungs, and we presume that your lungs are clean. So I think if the air that you're inhaling is clean and safe, then even if the exhaled air mixes with it, it does not pose any risk to you. In terms of the carbon dioxide, it goes out through the filter. So it circulates inside. It's not only pumping air into that face hood, but it also is extracting as well. So although I did an endoscopy and I wore it for maybe 40 minutes, I was quite comfortable with it. But I'm sure if I'm doing a 3-hour, 4-hour worth of operating, then it would be a different story.
Yes, sir. Sir, we have another question by the participant. What if there is an endemic in danger of ruptured appendix during these times?
You have to, so I think there will be cases who, the fact that we have COVID does not mean that patients will not have heart attacks and strokes and ruptured aneurysms and ruptured appendix and perf DUs. So those patients would still need treatment. And I think it is the duty of the healthcare system to have designated areas in a hospital or designated hospitals who have the facilities to perform these procedures safely. So I think I would under no circumstances even think of allowing a patient to die during COVID just because we are worried about contracting COVID. I think as doctors, it's very difficult to find a doctor who knowingly would allow a patient to die. So I would rather concentrate on getting the appropriate protective gear and treat every emergency that needs to be treated on its own merit.
Yes, sir. Thank you. Sir, there's another question. Did the pandemic cause a significant shortening in post-operative stay in the hospital, or were the previous protocols regarding post-op stays followed?
I think we are actually writing a paper about it. In Cleveland, because our hospital was declared a COVID-free hospital right when the UAE was coming off the peak. We were still at the peak, but just trending down. And the hospital decided to start the elective activity with full protocols. And so we have the highest number of elective cases. So in July, we performed 64 bariatric procedures. In August, so far, there are 50 patients who have either had the operation or have the dates during this month. So, and this is the activity which is come back to our normal elective. In fact, the July was the bit of backlog as well. So I think the protocols are elective. Inpatient stay is 2 nights after gastric bypass or sleeve gastrectomy, and that has not changed. We have actually returned back to our absolutely normal protocol. If someone wants to go home early and if they're clinically stable and there's no risk, then we allow that to happen. But the situation during COVID, you would sort of encourage patients to go home early because the risk of contracting COVID after surgery within the hospital would be high either through another patient or through a staff member. But if it's a COVID negative hospital and you have good protocols in place and you have good resources, then there is no significant need to alter your protocols because you have to weigh it against the potential risk of discharging patients too early and hence missing a potential complication.
Yes, sir, of course. Sir, is paper recycled after use or thrown, or is a new one worn anytime after it's disinfected?
It's a re-sterilizable piece of equipment. Obviously, the tubing that connects from your waist belt to your face hood is changed every time, but it is cleaned thoroughly, and there is a special sterilizing system that cleans. So we put 5 together in a sort of a cabinet, and it goes through its cycle of about 3 hours or so, and it's recycled after that.
Okay, sir. Sir, we have another question. What is the accuracy of the rapid testing methods?
So it is PCR. So the rapid testing is not the false positive of the 1 hour test is high, but the false negative is about the same as the routine PCR. In studies, unless I've not looked at a more recent study, there's about 30% false negative for routine PCR. And the false negatives are, number one, because the sampling is not done appropriately. You haven't gone far back when you're taking the sample, which means you haven't done the brain biopsy properly. Secondly, the patients who were tested, they were tested at the time when they were not in their infective phase. So combine these two, there is 25 to 30% false negative for COVID. And the rapid test, which is again a PCR, is 5 or 6 times more expensive, but it is a PCR, and the false negative again is about 30%. So that's why even in a patient who you suspect symptomatically has COVID, even if they are PCR negative, treat them as COVID and take all the precautions.
Okay, sir. Thank you, sir. Sir, so in such a case, would you recommend antibody tests? For example, if the PCR does come out negative or the rapid testing does come out negative and there is a suspected thing that maybe the healthcare worker specifically might have COVID, so in such a case, would you recommend it?
To be honest, I don't know. I can speculate and I can guess like many other people, but I don't think it's appropriate for me to say one way or the other because I don't know the answer to that.
Of course, sir. Thank you so much. Sir, another question is, what's the psychological impact of COVID on post-op patients? Any observable changes in duration of recovery during the last 4 months versus normal times?
I think COVID physically takes a lot out of you. Even patients who did not need to go to the ventilator, their energy levels were very significantly decreased. And psychologically, it affects you a lot because you hear so many horror stories that when you get COVID, the first thing that comes to your mind is that you're going to die and what will happen to the people behind you and all that. And I think I have a patient who was on elective list for bariatric surgery and then had COVID, and she's desperate to have surgery, and she's had 3 negative tests. And I'm still trying to postpone her for at least 2 months from the last 3rd negative test, simply because currently we know very little about what happens if you operate after they had COVID and they have become negative, because there's very little data out there. So I think I've agreed to operate on her 2 months after her 3rd negative test. She's absolutely healthy, normal energy. But my simple answer is, just from observation and observing people that I know who had COVID and patients who had COVID, is that it takes a lot out of you. And if you can avoid elective surgery, I would leave it well alone for 3 months, unless it's really affecting your life.
Okay, sir. Sir, I'm 100% sure. And keeping this in mind, I'm pretty sure the psychological impact on surgeons particularly is so high that I'm sure, would you like to say something to our fellow surgeons regarding this, maybe some motivation?
I think it's manifold. One is at a personal level, that as a surgeon, at least most of the surgeons that I know, our happiest time is when we are operating. That is when we are in control of our situation. That's when what people are saying outside, or what the politics is saying, or what the administrator is saying, doesn't matter. You are operating and you are at your best place. So this COVID has taken that away from a lot of us, or it did for most of us. So it took it took our prime time, it took our sort of the reason for existence away from us for some time. And I think it sort of takes control out of you. And when the control goes out of your life, then it makes you vulnerable and uncomfortable and uneasy and unhappy. But it is important that in order to get back to that good place, you do not rush and you do not do things that harm you or your patients. I think the first principle is do no harm. And I think we are very lucky in Pakistan that the COVID has not been as deadly as it has been in the Europe, in UK or US. The numbers, despite our inadequacies, despite our deficiencies, despite our lack of planning or ill discipline, I think Allah has been very kind that we did not suffer as expected or as we had feared. So the good times, inshallah, are coming back. That is my message to my junior surgeons. Please look after yourself. Do not rush and do not cut corners in protecting yourself. Even if you have to invest your own money on masks, do it. Yes, it's the responsibility of the hospital and healthcare system, but there's only one you. So that you is protecting is your own responsibility. And inshallah, good times will come and there will be plenty of opportunities for you to operate again. And I hope that that time comes soon, inshallah.
Inshallah, sir. Sir, so how do you surgeons deal with the psychological pressure with the added burden of the fear of corona, and how have you managed to balance work and life in such a time?
Well, I tell you, when this happened, my hospital cancelled all elective activity, and so we stopped seeing the patients in the clinic, we stopped operating, and some of us were redirected to look after ICUs. Our operating recovery area was converted to ICU. And I got the opportunity so we had some free time. So I used that time to upgrade our hospital in Muzaffarabad to a COVID facility. So we did online training and upgrading of the facility. Every day I was on online communication with our staff for a few hours. We got people from UK, from here, to train our nurses, doctors, and we were the first people to provide protective gear for our outpatient facility. But and I was fortunate that I had the opportunity to put my time to a better use. But my colleagues who just sat at home, they were actually bored after a week, and they were struggling to keep their kids busy. So it affected different people differently. People had great time at home, and people who were not getting along well had terrible time at home, including with their kids. And some really struggled. Work-wise, I think coming back and your true personality comes out at the time of stress. And some of our colleagues went off sick with stress, and some of our colleagues found new interests, and some came back rejuvenated and recharged. So I think it really depends on your substance, what you are, and at the time of stress that gets enhanced. Overall, I think, again, my hospital was very good. We had special sessions, including well-being sessions and online sessions in the evening, where one of the good speakers would come and help you psychologically to cope with. So I think these are all benefits of working in a resource system. But in our system in Pakistan, we have people who are older and wiser and who can share their wisdom and who can share their kindness. And I'm sure a lot of people did that in Pakistan during this time, and that's what kept things going.
Thank you, sir. Sir, even though UAE is such a resource-rich country, was there any backlog in the supply of PPE in the first weeks of the pandemic?
Well, I tell you, I'm surprised at how, and I'm not just praising the government because I live in this country, but because I've benefited from it. There was no time when there was any shortage of any food supplies in the supermarkets, the masks for public to buy for their own use, or the hand sanitizers, and the prices did not go up. So the government made sure that everything that was available prior to pandemic was available at the same rate, and there was plenty of that. The hospitals, um, we actually donated PPE to UK. UAE government did that as a gesture of friendship. So our hospitals did not. Um, there was some rationing at the beginning, but there was never actually a true shortage where you needed the equipment to treat a sick patient and you did not have the protective gear, at least not to my knowledge.
Okay, sir. Thank you. Sir, we have a question by Dr. Shahid. Is high frequency ventilation better than volume ventilation to avoid barotrauma?
That's a question in terms of the use of ventilator. Now, you know that I was involved with helping ICUs in Pakistan. I'm a surgeon, so again, I think I would be guessing, but I'm very happy. We have got about 10 or 12 ICU consultants in UAE, USA, and UK. Through our network, we have helped many ICUs. And if there are any questions specific to ventilator or settings, or actually there's a patient in any ICU where the staff needs help, then please feel free to share my WhatsApp number. There's still plenty of intensive care doctors within our group who are very happy to help and answer any questions. But I'm sorry, I don't know the answer to that question.
Okay, sir. No, thank you so much. Sir, in that case, how effective do you think eICU is during these times?
I think our experience, we have worked with ICU in Quetta, in Faisalabad, Multan, and Azad Kashmir. And I think they are a huge resource as long as it is used appropriately. So you cannot replace the physical bodies in an ICU. So you need people who can intubate, you need people who can physically see the patient, but you don't necessarily need people who are expert in all aspects of intensive care. You need people who have basic knowledge, and then someone sitting on the end of a phone or on a electronic system can actually guide. They can do virtual ward rounds where you can take a system where they can physically see the patient, look at the monitors, look at the parameters, blood tests, and help advise changing the treatment management and the settings of the ventilator. So I think it's a huge resource. We have identified, I'm not an intensivist, but majority of my work during the COVID through our Midland Doctors Organization has been helping ICUs, including development of ICUs. So there is so much we can do by just connecting the resource to the need. And for people like me who are sitting abroad and who have close contact with Pakistan, there are many dozens or hundreds of people like me who either have the skill or know someone who has the skill. And we are very happy and keen to connect that skill and resource to the need in Pakistan. And I think the simple answer is it's a huge benefit and it should be utilized more.
Yes, sir, definitely. And thank you so much for your help. I do know everything that your NGO, Midland Doctors, has been doing for Pakistan. Sir, in that case as well, which parts of the COVID surgical protocol in the UAE have you experienced that could be applied to Pakistan, especially keeping in mind how our resources are not as great as the ones based in UAE?
Sure. So I think one thing that I would very strongly recommend, one thing is related to patient, that every elective surgery must have a COVID test. from a source that you can rely on. I'm sure there are a lot of labs who would just print the results, but it needs to be a lab where you rely, or your own hospital does it. And secondly, even if COVID negative, please use the basic requirement of a N95 mask and protect yourself. So I think these both things are applicable in Pakistan, even in the most basic settings. And the from a hospital administration point of view, the emergency, the doctors who are exposed to the emergency patients, I'm not just talking about the operations, but the outpatient facilities like ENT or pulmonology, then you need to take extra precautions and make sure you have, I know it's summer and it's hot and it's uncomfortable, but still I think it's applicable, and I think it is, I would say it again, it is your responsibility to protect yourself. The government is under-resourced, and I've been involved in trying to develop ICUs in different parts, and I know people in power, I'm not talking about the politicians, I'm talking about the people in power in hospital administration. They just want that there's no extra headache for them. Kaam chalta rahe, unhe koi tang na kare. Development or no development, they're least bothered with that. That has been my experience, and I've been working with this sector for the last 15 years. So I'm not sort of claiming it by sitting outside, but this is by experience, by working very closely as recently as last few weeks.
Very well said, sir. In fact, there's a Dr. Sahib Zadi Hina who wants to know a little more about your experience in Muzaffarabad.
So the Muzaffarabad hospital is a 90-bedded hospital that we designed. So we started with at the time of the earthquake in 2005. I traveled from UK along with a few colleagues, and we set up a camp in Balakot. For a week, we operated through a tent. We went back and we decided to do something long-term. So we made a small charitable organization, and we gathered funds, and we spent about 50 crore rupees to build this hospital. And we have been running it for the last, we opened it in 2013, and we have treated more than 300,000 patients. We do general surgery, laparoscopic cholecystectomies, hernias, urology. We have a lithotripsy now. We starting our cardiology service. We have dentistry, pediatric nutrition programs, including community program. And so far, everything is free to the patient, including the operation, medication, X-ray, lab, everything. We've got 7 founding members. We do not take a single penny out of the charity. We travel at our own cost, and we have a lot of volunteers who travel with us from Cleveland Clinic, from UK, to provide free surgeries, and physicians who travel to do clinics. We have paid staff, obviously, in Muzaffarabad. Total, we have about 75 staff members. And we continue to, as the funds come, we continue to try to improve and expand our services. And at the moment, it's completely free, and it's a Zakat eligible facility funded by donors from UK, UAE, and all over the world, basically.
Okay, sir. Sir, that's amazing, mashallah. Sir, Dr. Hina wants to know when you think the pandemic will come to an end.
Well, I think we will have to learn to live with it. I don't think there is going to be an abrupt point where we say, okay, and this is over, let's go and start our normal life. I think this will be our new normal. And it will, once the vaccine, successful, cheap, and reliable vaccine comes out, then we will return to some level of normality that we knew beforehand. But even if the vaccine comes out today, the number of ampules required, and it would go to a resource countries first. And it's like polio has researched in Pakistan, it's finished all over the world. But even if there is a small pocket of infected people anywhere in the world, it can come back again unless everyone is vaccinated. And the vaccine, who knows, like influenza vaccine, every year there's a new strain. So I don't want to depress you. I don't want anyone to go and jump off the bridge. But I think we just need to be realistic that the norm that we knew beforehand would be significantly different. And human beings are very adaptable. And I think we will adapt to it just like we adapted to many things before this. But it will take, in my view, it will take at least the end of next year before this vaccine is freely available and people can afford it. And we are returning to traveling very frequently without fear and getting on with our normal life business. But having said that, it should not restrict us from enjoying life within what we have.
Yes, sir, absolutely right. Sir, with your permission, I would now like to conclude the question and answer sessions. Thank you so much for sharing such valuable insight and taking out such precious time all the way from Abu Dhabi. It was really a wonderful learning experience for all of us.
Thank you very much. I just want to, number one, I saw how you both conducted the first part of the session. Well done. I'm really, really very pleased to see young people coming forward, taking the responsibility and doing it so well. It really warms my heart to see the young people in Pakistan, mashallah, doing so well. And well done to you both and to your organization, everyone who's behind this project. I'll be very happy to support you and participate again if required and help you guys in any way.
Thank you so much, sir. That means so much.
Okay. Best of luck and thank you very much again.
Thank you, sir. Have a good day. Thank you.
Okay. Bye-bye.
Dr. Zaid, over to you.
Okay. I would again like to extend my thanks to Dr. Javed Raza for a very insightful and informative session. So this concludes the sessions for tonight. I would like to thank both of our speakers for giving their time and valuable information and for being able to share all their different experiences related to COVID-19 in the surgical practice. Thank you for all the participants for joining us, and we hope that you've gained as much information regarding elective as well as emergency surgeries and the different protocols that must be undertaken in the COVID-19 pandemic. Do not forget to fill the feedback forms, and as certificates will be distributed based on that. Thank you, Dr. Mehwish, for being an amazing co-host, and the rest of the team for helping us conduct this session. Our next session will be held the following weekend on August 22nd and August 23rd, and same time, same virtual space. The sessions will be related to gynecology and obstetrics and ophthalmology in COVID-19. See you all then. Thank you from my side. Dr. Mehwish, over to you.
Thank you so much, Dr. Zaid. It was a pleasure hosting with you. Thank you to our speakers for sharing such beneficial information and taking out so much time to increase everybody's knowledge. Thank you to all the participants for tuning in. Like Dr. Zaid said, please do not forget to fill out the feedback forms as we only leave it open for 45 minutes. After that, we will not be leaving it on again. Thank you to, and especially a special appreciation for Professor Samia for all of her efforts. She's our patron as well as our advisor for the academic team, and the series would not have been possible without her. Thank you, Dr. Sabah Akhtar, co-founder of VFP, and also the advisor of the academic team. She has been the backbone of our team throughout these sessions. Thank you, Mr. Iftikhar Yazdani, CEO of Rahe Qamar and a partner of VFP. His company provides voluntary IT services for this noble cause. Thank you, Dr. Rabil Tariq, co-founder of VFP. Thank you so much, Dr. Maham Khalid, who is the co-director of the academic team along with me, Dr. Suhaib, Dr. Ibrahim, and many others, Dr. Qadir Zafar, and Dr. Muhammad Ali Bhatt. Thank you for supporting us throughout the session. Thank you on behalf of Team VFP, Team RMU, and Team Yarden. Allah Hafiz.